Hello. No, I'm on. Okay. We're having a little bit of technical problem, but we're going to proceed. Can everybody hear me?
Yes, I can hear you.
Good afternoon and welcome to this edition of the Black Health Trust. I'm trying to give Simon another minute or two just to fix the technical problem. It went out in Florida. It might have been that governor down there who pulled the plug. I want to say good afternoon to everybody. I see a lot of names that I recognize.
That's funny.
I see we're represented in Bakersfield and Vermont.
Yeah, New Hampshire.
And DC. And where else are people on here from?
Cincinnati.
Cincinnati?
Brandon, Mississippi.
Wow.
Philadelphia, Pennsylvania.
Okay.
Billy in the house.
Yeah, you are very important. Get out there and make them people vote.
Oh, yeah. We're going to have a special concert tomorrow evening.
Okay. So I'm going to start. Two of my usual co-moderators are out today. Dr. Neighbor Stevens is transiting from Florida to Tennessee. And Dr. Walks couldn't be with us this morning. One of our constant attendees is going to work with me on some of this data is Dr. Lawson. So we're looking at not having lectures and showing slides so much as giving common information. Recent events have demonstrated that the circle of many of us is getting smaller and smaller. And recently, last week, I think I mentioned it then, I lost a dear, dear friend who was also an MD, PhD. He was a radiation oncologist named Dr. Joe Simpson. And we've known each other since junior high school and high school. But he transitioned. He was 4 months older than me. And I'm still pretty young, I think. But I want to talk about two items today. And I'd like Dr. Lawson to join me when he can or will. And I want to talk about common things that are affecting older Americans. And two of those are urinary tract infections. And the other one is Alzheimer's disease. So we're going to talk about urinary tract infection first. So just to be simple, to get us all on the same page. So what is a urinary tract? The urinary tract is a set of organs in the body that handles urine. It includes the kidneys, and the kidneys are two bean-shaped organs that are located in your back, right where your ribs meet your backbone. And your kidneys are about the size of your fist. If you made a fist, it'd be approximate the size of your kidneys if you're healthy. As your kidney health decreases, those kidneys contract and become smaller. Coming down from the kidney is a tube called the ureter. And the ureter connects and takes the urine from the kidneys into the bladder. And the bladder is like a big balloon that sits right under your umbilical cord, so to speak. And then from your bladder, there's a tube called the urethra that excretes the urine either through in the female your vaginal area, on the male your penis. So when we talk about a UTI, we're usually talking about a simple UTI which affects the urethra and possibly the bladder. If we talk about a more serious thing where the infection actually travels up the urethra and gets in the kidney, it's called a kidney infection or pyelonephritis. So that at least puts us where we are. So when you have a UTI, many people will feel a burning sensation when they urinate. They will have urgency. They may have to go a lot. They may get up at night to pee, even though other reasons to get up at night to pee. But as we get older, this gets more dangerous and we have to be able to treat it. We stress for women who get more of these UTIs than men that when you urinate and use the bathroom and you clean yourself and wipe yourself, you should wipe from the front to the back. And that helps prevent fecal material from getting into the vaginal or urethral area. We also suggest that if you have coitus, also known as sex, that you urinate after that, and that helps flush the bacteria out. We also want to stay fairly well hydrated, as movement of water helps that process. But if you have a urinary tract infection, you want to treat it as soon as you can. Now, there's some people who recommend cranberry juice, which can be effective in denigrating some urinary tract infections. It's usually with something called E. coli. It's the most usual bacteria that causes urinary tract infections. And we can treat that with a number of antibiotics that your physician or provider or nurse practitioner can provide you with. And you can be treated anywhere from 1 day to 3 days. If you have an actual kidney infection or pyelonephritis, it may take up to 10 days. For those of you who are not allergic to sulfur, one of the best treatments for urinary tract infection is a sulfur drug called Bactrim. And it's called trimethoprim sulfoxazole. And that is a very good bladder disinfectant and can work a long term. Now, Dr. Lawson, you with us?
Yes, I am. Can you hear me?
Yes, I can.
Yeah, and I just want to, I'm glad you brought up urinary tract infection because, and why would a psychiatrist be involved? Well, because one of the presenting features, especially for many elderly women, is change in mental status. And I've had several cases in which folks were diagnosed as being demented. I had a psychotic episode and was subsequently found to have an untreated urinary tract infection. Untreated because the whole idea of having something going on down there was very embarrassing. They didn't talk about it. I never thought about it about men until I had my own personal experience. I was talking to my wife one day and she said I was talking gibberish. And I said, what do you mean gibberish? And I was feeling I was on Mars or on another planet or something. Went to an emergency room and I found out that I had an undiagnosed urinary tract infection. And that literally was the only symptom that I had. I quickly responded to antibiotics, but then quickly found that a lot of my elderly colleagues had a similar experience. For men, of course, the risk factors related to having prostate problems. But the point is that a urinary tract infection does not have to present in the traditional way, but many times can present with change in mental status and literally no other symptoms. And if untreated, can have very, very serious consequences. I was fortunate, and I was called earlier, did not develop full-blown sepsis, but I knew some other colleagues, male colleagues, who ended up in the intensive care unit because of a failure for anyone to understand what was going on. Worst case scenario is when folks literally end up in a psychiatric hospital. Folks just aren't even thinking about that, and may go for several days without being adequately treated.
Thank you, and that is so true. So the mental health implications are serious that can happen with the urinary tract infection. The other thing that happens many times, one of the symptoms, some people lose control of their bowels. They are disoriented, they're unstable, they have falls. All this can happen. And there are other symptoms that can occur. If there's fever, there can be back pain, nausea and vomiting, and that may happen especially if that infection moves up the urinary tract to your kidneys and affects your kidneys. So a change in your mental status, a change in your bowel status, all of these might mean that you have a urinary tract infection.
Let me mention one other quick point. That is that looking at vital signs. In my case, I didn't have any change in my vital signs. And that's what I think, unfortunately, is all too common as you get older. Your autonomic nervous system simply doesn't respond as quickly or does not respond as well. So folks don't, in an infection, do not get febrile. They do not develop a cough. They do not develop chills. Just don't develop anything but the change in mental status.
Thank you so much, Dr. Lawson. Are there any comments or questions so far on urinary tract infections? I know this is a little bit lower brow than heart failure and all that, but it's something that is common and very important. The takeaways from this are good hydration, drink plenty of water, make sure that you urinate after sexual activity. Now, also, since we have people who are parents, it's good to teach your children to urinate often, not hold their urine. So they should be taught to periodically go to the restroom and not hold it. I have one friend who just holds her urine all day and she ends up with frequent UTIs. Now, sometimes if you have frequent UTIs, that means you can have an anatomical problem with your urethra, maybe the way that you're cleaning yourself afterward. Some people get urinary tract infections after losing their bowel control in bed and not being careful about that. So there are all sorts of problems we need to look at. Any comments, expert or non-expert?
I just want to mention one other point. We just note that Black Psychiatrists of America is having his annual spring conference in the next couple of days in Kenya. And it's just around, I'd like to remind folks, when we get these long intercontinental trips, go to the bathroom. Often folks do not go to the bathroom. They sit on it. They do not take care of the urinary needs. And unfortunately, when they come out at the other end of the trip, sometimes can be severely ill, not because of the trip itself, but because they simply do not take care of their ongoing regular personal hygiene like they should. So it's very tempting when you're in a long meeting and long trips to say, I'm not gonna go out and try to get into one of the plane's bathroom. I'm just gonna ride it out. And the results can be sometimes catastrophic.
That's a really good point. Really good point. The other thing, since you mentioned travel, I recommend there's something called TED hose or support hose that many people should be wearing when they're on these long plane flights and sitting around, and the circulation in your leg, particularly the circulation returning back towards your heart, is compromised, and you end up with swollen legs, and some people end up with the pulmonary embolus from sitting still like that. So it's a good idea as you get older to wear, we used to call them knee socks, but they're socks that contract and help return blood to your heart. So that's something to do. So don't let down your guard. All right. So let's go to an area where Dr. Lawson is much more of an expert than I am. Many people have heard of Alzheimer's disease. And Alzheimer's disease affects everybody's family somewhere, whether it's you or your grandmother or uncle. And I read an article just the other day. I'll ask Dr. Lawson to comment on it, that there's a group of people who have a genetic abnormality that have difficulty absorbing omega-3 oils, and they do better when they have an excess in their diet of omega-3 oils. But this is a form of dementia, meaning, and it occurs in some people slowly over time. It has to do more with initially recent memory, and it affects many of us, and we have to be very careful about that. Dr. Lawson, you want to comment on Alzheimer's disease? And we're going to do a show on this later, but just
Yeah,
now.
it's special interest to myself and actually to African American psychiatrists in general, because the first African American psychiatrist was noted for the fact that he was working in Alzheimer's lab and was told to study this condition. At that time, it was thought that it was an inevitable consequence of aging, but he found that no, that was not the case, that the people that developed cognitive impairment had changes in the brain that was that was causing this, and that you could identify these by what we call changes in terms of the nervous system, that there was an accumulation of these plaques that were around the nerves that affected them. And ultimately, these plaques caused the nerves to die off. So it was first recognition that this was a very unique disease itself. And the psychiatrist, Dr. Fuller, continued to work with this. He's Liberian born psychiatrist and family actually came from Petersburg, Virginia, getting away from the racism of the U.S. While Alzheimer's is listed as a discovery of these Alzheimer's plaques, there's some of us
So some of the symptoms that I think, Dr. Lawson, include forgetfulness, acting confused or disoriented, trouble writing.
Yeah, the idea is that what the plaques do is they affect the connection between the hippocampus, which is involved with short-term memory, and the rest of the brain, cutting it off. As a result, the initial symptoms are problems in terms of short-term memory. Then later on, goes on to impaired disorientation in general, spread to the rest of the brain, and then ultimately the person develops a severe dementia in which most functioning is impossible. And so much of the treatment has been involved in terms of focusing on identifying these plaques. There's a genetic component to it. We found there's a relationship between the lipoproteins, which produce some people increased risk. But in very recent years, especially in the last couple of years, made us an interesting discovery. And that is that while we've been focusing on the genetics, lifestyle plays an important role in terms of the development of this very debilitating illness.
You mean how you eat and what you eat is important?
It's very important, and how much you exercise. And so people with diabetes, hypertension, and as you missed the value of getting certain kinds of compounds in, risk can be important in terms of preventing the occurrence of it. In fact, the lifestyle issue may account for over 50 to 75% of the variability in terms of the occurrence of this disorder. We were involved in a major study comparing the risk of Alzheimer's in the U.S. versus Alzheimer's in terms of Nigeria. Found out that the ApoE story did not apply to Nigerians, and that African Americans sort of fell between white people and Nigerians in terms of the role of ApoE. And we've since found, again, that certain parts of Africa, this disorder is almost unknown, but in other parts it's very, very common. And a key factor, in addition to the genetic factor, is the importance of lifestyle, of making sure that you can address problems like hypertension, diabetes, and etc. So these findings are a game changer because there's been tremendous failure thus far to find effective treatment for this disorder. We've been looking at trying to somehow restrict the production of amyloid, when in fact, some of the best results may be excellent work going to Dr. Abisason at Howard University. Exercise and diet may be at least as important, especially in terms of the African American community. And this disorder is twice to 3 times more likely in African Americans. We don't see it as much because we didn't live long enough before. But now that we're living, getting old, we're starting to see this disorder almost as an epidemic that's happening in terms of our community.
Let me make a couple of comments, because some of the people on this call are caregivers of people who are affected by this. So it's important that we keep these individuals safe. And sometimes the people with this type of dementia have problems with falling. If you have like loose throw rugs in your house, that can be a problem. And you should have non-skid backing on those rugs. We need to make sure you tuck away any loose wires or electrical cords that you have around the house and on the floors. And they should wear sturdy, comfortable shoes. And keep the walkway should be well lit and clear. That's the very thing. Make sure that these people are safe. And they need to have physical activity, as Dr. Lawson said. They need to exercise, they need to walk, they need to have as healthy a diet as possible. And they sometimes also have trouble with social interaction, so you have to be careful with that. So some of these symptoms I read, I remember in medical school, every time they talked about heart attacks, I had a heart attack. And then they said, shortness of breath, I'm short of breath. And now Dr. Lawson talking about memory loss and short-term memory, I can't remember my words. So, but many of these things we notice, and we need to keep our minds active and busy. We need to eat right. And we've always talked from day one on the Black Health Trust, talked about exercising at least 150 minutes per week, eating a healthy diet, eating fish, especially fatty fish, things like sardines and mackerel and salmon. All of those play a role in keeping healthy, not only from cardiovascular disease, which is related, because we know there's something called white matter disease that affects the connection between the two hemispheres of the brain, and that can happen a lot with cardiovascular disease. So all these things are related. We know that there's Alzheimer's, and some people call that diabetes 3. We'll leave that for another conversation. There's diabetes itself, there's cardiovascular disease, heart disease, kidney disease, and believe me, all these things, even though we talk about them separately, they're all a part of a big conglomeration of things that can go wrong. If something is wrong with your kidneys, it's going to be very soon wrong with your eyes. That same thing happening in your kidneys and your eyes is also happening in your brain and in your heart. So everything is connected. So we're talking about simple things, not big earth-shaking things, but these simple things that can combine to make you quite sick or take you out. So I'm trying to live. My relatives have lived to be 100, 102. I want to get close. I don't know if I'll make it. I started late, but I'm trying to eat right, walk, and exercise. Any more comments, Dr. Lawson?
Yeah, I just want to know, you mentioned caretakers. One thing I want to think is that caretakers also develop kind of psychopathology called major depression. And what we find is that substantial number of caregivers become depressed in their role and becomes the risk for all the consequences of depression in terms of suicide. So we need to make sure that our caretakers are taken care of. The other is that what we also find is that, especially in the African American community, we don't put folks in nursing homes like other groups do. We keep them at home. And so family members need to be aware. Everything Dr. Maxey talked about, family members need to be aware and to address when some of their family members start showing some cognitive impairment. One of the toughest things that happens is that since Alzheimer's is insidious, folks end up as drivers. When they're driving the car, is it safe for them to drive the car? Should you take the car keys away from them? We have what we find is that while being educated is actually protective in terms of Alzheimer's, on the other hand, it's a real challenge when we have someone who's a professional, who's a physician even, or who has high executive functioning, begin to show early signs of Alzheimer's, which has implications for their system, for caregiving, and for the community. So and then I wanted to note that Alzheimer's isn't just a brain disease. We find evidence of it. We're finding olfactory bulbs, perhaps in the years that we sell throughout the nervous system. We're just beginning to appreciate the extensiveness of this. And a good 20% of Alzheimer's folks have developed psychosis, frank psychosis. And as a result, end up with the wrong treatment because some of our medications are devastating for Alzheimer's. The challenge is, given the folks develop Alzheimer's, become, quotes, agitated, combative, difficult, which we unfortunately see all too often with higher functioning people who start seeing cognitive impairment, loading them up with medication, and then you start seeing falls, start seeing accidents, leaving the food cooking on the stove too long so it gets the whole house on fire. See those kinds of things happening. So Alzheimer's is a problem and a community issue. It's not just caretaker. Community issue. The family needs to be involved, and the community needs to be able to discuss this disorder forthrightly, because it's embarrassing to say, "My gosh, you're not as sharp as you used to be. You're not the person that you were in the past," and folks just don't know how to deal with these issues. The African American community can teach a lot about this, but we often try to work with this outside of the standard nursing home system. And we've developed strategies for it, but at the same time, it creates new stresses in our community.
Let me put a question to you. I just got a notice on my phone. It says Alzheimer's researchers say brain stimulation device may slow symptoms. Are there any brain stimulation devices you know about?
Yeah, there's some evidence that if you do direct brain stimulation, it may do a little. I haven't seen any evidence that it's clinically useful. We have medications that may slow symptoms. Some of them just getting approved. But I think using brain stimulation, I think has some promise. But there's some real issues in terms of practicality. You can't do the ideal thing if we could do something like a pacemaker, the heart, if a person with Alzheimer's can weigh on the head and see if that keeps the brain activity going. But the most effective brain stimulation device is intellectual stimulation, reading,
That is so important.
writing, and getting involved.
So
And
we have
that's
to
really
keep
the
conversation with our patients, right?
Right, exactly.
So let's open the phones for some other comments. I see some notable people here in the Pittsburgh area. I see Dr. Rhonda Johnson. Up in the state of, not Maine, where are you, Dr. Sander?
Hi, Dr. Maxey. Yeah, I am in New Hampshire, and we have very limited up in New Hampshire, very limited access to quality health care. It's It's like being in a place that's a rural setting, and you have to find the university healthcare centers like Dartmouth, or you have to travel into Boston. And even if you want to make an appointment for primary care, you may have to wait months. And it's real difficult up here as opposed to when I used to live in New Jersey, and you could get appointments the same day. Very, very different. So healthcare, we have to remind ourselves, is not a national thing. It's more of a localized, regional, but very localized type of situation. And it can be very different for people in very different counties in the same state and in different regions of the country. So access is our major problem up here. But even when you get access, costs are difficult. Insurance is like anywhere else right now is almost you can't even obtain it because there are very few large businesses that offer insurance. Most of what operates up here are small businesses and they can't afford the costs of insuring people well. So we're in crisis in a state like New Hampshire, very similar to other places in the country. And we also weeks ago we discussed the fentanyl overdose problem. And if you look at New Hampshire, I think we lead the country per capita, and yet we're a tiny, tiny place. So we have our problems. You may not think so because most of the country is pretty far removed from us. But there's a lot of great things up here too, which is the outdoors and the freedoms and low crime, etc. But there's a lot of drinking, there's a lot of drugs, and there's we all, face very similar problems, whether we're urbanized or out in a rural setting. And I can tell you things were a lot better in New Jersey, believe it or not. I know it's hard to believe, but I promise you that from a healthcare
Well,
perspective. So
thank you, Doctor.
that's it.
Yeah, I just want to note that some of you know I did part of my I went to graduate school in New Hampshire.
Mm.
I'm from a small rural community in 150 miles from Washington, D.C. Always complained that we had limited care, limited resources. So so when I had a chance to go to school in New Hampshire, I said, oh, I'm going to heaven now. There's going to be all kinds of health services and availability of services and so forth. And got a startling discovery as you discovered. And it's not just lack of availability of care. When I was there, the state was so very, very conservative, strong belief in terms of Yankee self-reliance, and this whole idea about getting health care, going up to doctors. There was a strong philosophical bent against it. You go to a doctor when you couldn't stand it anymore. Then you could go to a doctor. But even now, what we find is that when we come in with new treatments, especially some of the doctors in the rural communities, they're just if they're not super aware of it, they're very suspicious of it. I had a heck of a time convincing some neurologists that by gosh, we do have medications that can slow the progression of Alzheimer's. They just didn't believe it. They wanted to give them something, treat it like it was pneumonia and have it go away overnight. And of course, it didn't happen. So you're absolutely right. There are places like New Hampshire and again like parts of Virginia and throughout our country in which health care is not very available, especially for people of color. And
So let me ask you a question, Dr. Lawson, and if you can answer this question apolitically as you can, since we're a nonprofit. I like your comment on the mental status of certain politicians without talking about name, but just say in what age group. Do we have any problems that are current, or could you comment on, we don't want to use names or politics?
no, I think it's a very important issue that may influence and has influenced elections. When I was in New Hampshire, I was involved in terms of multiple political confrontations dealing with the whole issue of whether or not vaccination of kids was an insidious plot to kill kids. Even recently, I had issues with folks in terms of DC, whether or not we're putting something in vaccines that's going to kill Black folks. There's a very prominent colleague of mine whose sister led a major effort to keep Black people from those awful psychotropic medications. So there is a real issue in terms of suspiciousness of the medical establishment. It's not just Black folks. Many folks in many rural areas, low-income folks, other ethnic groups were very concerned that treatment, especially new treatments, are in some way making people sicker rather than better. And yet the evidence is strong that we're getting much better results than we had in the past. But the memory of most people is what they know in their lifetime. They don't remember back in the old days when things were much, much worse. When you see measles encephalitis, which I saw, or which medical students rarely see now. And so why do we need to give folks measles vaccines?
And what do you think about the mental status of the two oldest candidates in the past few months for president?
Yeah, there's a colleague of mine, Bill Justice, get a chance to read some of his books. He makes a very excellent point. That is that while elderly may have less knowledge, less information, especially in terms of high technology, also have wisdom. And so you have to balance those two. What we find is that many times, especially in terms of politicians, to be elected, they have to, they many times may have good, what we call common sense, and they have wisdom, but they may be totally out of their league in terms of dealing with new knowledge and new information, either becoming over-involved with it, thinking it'll solve everything, or simply rejecting it. So that's a real issue. We don't, a colleague of mine wrote a science fiction story. We just give an IQ test to everybody. I don't know if that's a good recommendation. Or do a dementia exam. It does, being an effective, useful politician doesn't seem to depend that much in terms of whether or not a person is cognitive intact. So much so as whether or not they have what we call wisdom, being able to listen to advisors that make sense, of being able to select people around them that make rational decisions. And there's a huge debate about the extent to which another politician, Ronald Reagan, did he have, we know he had Alzheimer's, did he have early Alzheimer's while he was doing his presidency? Stories about Kennedy in terms of his treatment for his Addison's disease, how these can influence political decisions. Unfortunately, the general community just does not have this information, or may not be aware that treatments as well as these diseases affect thoughtfulness and political decisions that may have consequences for them as well.
Well, thank you so much. We're almost at the top of the hour. Just as we consider what time we're going to close out, I want to give everybody a chance to make comments, observations, ask questions. I see a very prominent doctor from the Pittsburgh area who's currently in Bakersfield. Can you open microphone? Is Simon still on?
Yes, mics are open to be unmuted.
Okay.
Well,
Dr.
good evening.
Johnson,
Hi.
go ahead.
Oh, this is actually Dr. Davis speaking.
Yes,
Hi, how are you?
but you're the one who introduced me to Dr. Johnson too.
Yes. Dr. Johnson's fabulous. So a couple points. Just to get backtrack to the earlier conversation. I was wondering, was there any link between UTIs and kidney, UTIs leading to hypertensive issues? That wasn't addressed.
The primary link that I was speaking about is the retinopathy that occurs with diabetes, simultaneous with the proteinuria and the problems that happen with the kidney and the problems that happen with the heart. They're sort of simultaneous. In fact, they mentioned when you have the diabetic retinopathy, kidney failure is only 12 to 15 years away. So they are connected in that way.
Yes, I can comment on that. Well, diabetic retinopathy is very common. There's different stages. There might be early stage of stage 1, which is, asymptomatic, or it may even be the presenting cause of why you can come to the eye doctor and discover you have diabetes. And that's usually associated with some blurring of vision, some problems focusing in and out, or premature presbyopia. And often we pick it up before the primary care doctor picks it up. We suspect diabetes because of maybe some early changes of that blood hemorrhages, and the patient has not had regular primary care. However, before severe retinopathy, it usually has to progress to, diabetes 10 or more years, and that's when you see the really significant retinopathy. However, diabetes could be silent or untreated, for many years before they present.
Let me ask you a question, Dr. David. So when you go to your primary care doctor and your internist, is it important that they look into your eye with something called an ophthalmoscope?
It is, but in all fairness to most primary care doctors, not unless they're doing a dilated exam, they might not see it. And it could be because early cataractus changes or refractive area errors, or just maybe not having the facility or the comfort level looking through, ophthalmoscopically. And also a lot of diabetics have tiny pupils or myotic pupils, so it makes it hard for a primary care doctor kind of to visualize some of these different things. And also I must say that looking with an ophthalmoscope, you're only looking at a small degree of the retina. So in order to get a really good view, you really need a dilated exam. And I don't recommend that in a primary care doctor's setting because potential or triggering, glaucoma attacks and other things like that. But I think it should be worthwhile, at least to get a quick look, at least, and have a suspicion. But if they've been diagnosed with diabetes, they should have a diabetic eye exam at least biannually. Usually, we encourage annually, but at least biannually. So if they have not had an eye exam, it should be highly recommended.
Well, thank you so much. The answer I was looking for is that everybody should at least have a look-see and know when to send them to a competent ophthalmologist like yourself.
Yeah. In other words, we're not asking you to be an ophthalmologist, but we're saying just take a quick look because you might discover other things other than just diabetic eye disease. You may discover some suspicious, or they may have some complaints that they've been suffering with, but just didn't verbalize them until somebody just at least took a look. And so, just utilize that. And that's also part of, I think, vision screening, is also, I think, part of the billable assessment. So it's worthwhile financially, as well as medically, and as well as humanistically, to just take a quick look.
Okay, thank you so much. Ms. Hazel, you want to comment or ask a question or make a comment? Ms. Tanner? What about Ms. Walker?
Hello, thank you. I don't have any questions, but this has been a wonderful review. I'm a retired public health nurse, and Hazel and I are retired from Minneapolis Public Schools as licensed school nurses, but this information is so worthwhile to pass on. I'm retired here in Mississippi, my husband's home state, but I'm also active in my church ministry, the health and wellness ministry. And so it's just good information, good review. I appreciate this program so much. I've been on since you first started, and I'm never disappointed. Thank you.
Well, thank you. What about a primary school teacher in Cincinnati, Ohio?
Hi, Dr. Maxey. Can you
Hello,
hear me?
I can hear you.
Yes, I thought this program was really informational, good information, especially the intellectual stimulation. A lot of people, when they get older, they kind of just stay to themselves, or they don't get out and, you know, get into organizations and volunteer. They need that stimulation to interact with other people. So, of course, my sister and I, we are interactive. You know, we're in card clubs, and of course, I still sub, even though I'm a retired teacher. But I try and stay active, you know, and keep my mind active also.
Let me just make a quick point on Dr. Maxey, noting
Yes.
how this all ties together. Intellectual stimulation actually results in brain changes for the positive. We've known this for some time. Your brain does not simply stop developing when you get in adolescence. It can continue, certain areas continue to develop long into the late 20s and 30s, and it has a preventive effect in terms of loss of cortical tissue. And we now recognize that you don't need as much brain. If you've done a lot of intellectual stimulation, your brain becomes more efficient and effective. So I just want, it was just like two things. Folks like to chase me around for a wheelchair. I said, worst thing you do is put me in a wheelchair, because I know that each mile I walk per day is another year added to my life. Same way with intellectual stimulation.
Let's say that again.
Each mile I walk, it is another year added to my life. When the other younger folks say, you know, you need to take a rest, sit down in your wheelchair, and then let's ride around a little bit. No, that's one of the worst things that can be done unless you are completely unable to function.
So
It
I'm gonna
prevents
get
fall, but it does not prevent, but it doesn't help your life expectancy.
I'm gonna get up out of here and walk someday. Are there any anesthesiologists in Virginia on the call?
I'm sorry I joined you late, but it's so good to be here. I'm so happy to be here. So sorry I joined you late.
Well, that's okay. But I know that you've done a lot of work in the Boston area. You used to work with the New England Journal of Medicine, and we've been talking about the effects of urinary tract infections and Alzheimer's disease, and the effect of diet on your survival. Any comments along those lines?
Well, I was in a meeting with an immunologist, and we were interviewing him for chair of the Department of Immunology. And he told me something that was really fascinating. They've done a lot of work with beta blockers, and they've shown that if a person's on beta blocker, it actually decreases their, first of all, likelihood of cancer. And secondly, if they have cancer, the advanced stages of cancer. So I thought that was fascinating.
Excellent.
Yeah, so we use beta blockers, as you know, for a lot of different things. But, you know, if you had a choice, most of us are on ARBs and ACE inhibitors. And I'm wondering if that there's a call for us to seriously consider that. He talked about a number of things, but that was one statistic that I took away. And I'm saying, why isn't this in the general medical literature? And why are we not talking about it?
So that's interesting. There was a study done some years ago called the CAFE study, and they treated two groups of patients. One was a group of hydrochlorothiazide and a beta blocker as the primary treatment, and one with a calcium channel blocker and an ACE inhibitor. And found out that they both controlled levels of blood pressure at good levels, but the people on the primary beta blocker died before. So I have, over the years, recommended that beta blockers be a secondary line of treatment along with ACEs and ARBs, but not a primary line of treatment. That'd be an interesting debate to have one day. We get Dr. Richard Williams and some other hypertensive specialists on. But I think that's extremely interesting. I also had an episode of bradycardia myself and couldn't figure out why I'm pretty fit and I was walking and all of a sudden I'm short of breath and couldn't walk. And I had an ophthalmologist tell me the eye drops I had a beta blocker in it called Timolol. And it wasn't the cardiologist and nephrologist who figured it out, it was the ophthalmologist who happened to be on the line with us as well.
And
So-
don't forget the cognitive effects. A lot of folks are using beta blockers for treating panic disorder and anxiety and so forth. And the advantage of long-acting beta blockers, it really work very well. And I think that they're wonderful alternatives to not putting people on benzodiazepines. But they do impair memory and they do have cognitive effects.
Now, the good thing about beta blockers, they're indicated if you have had a previous heart attack, if you have tachycardia, heart is going too fast, it can be active there. But you have to have a good combination of the appropriate drugs along with it. So again, we'll have discussion on that. We're going to spend the next few months talking about very basic things that people see every day. I really appreciate everybody for being with us. We're at the top of the hour. Dr. Lawson, any final words?
Yeah, I just want to also quickly note that we also use screening tests. A lot of primary care physicians are using psychological memory type screening tests. PHQ-9 is often used. It can be a that can be a very useful instrument for detecting depression and anxiety. But it should be looked at as a screening tool and not a diagnostic tool. Say you're going to go out and kill yourself tomorrow. So it actually can predict who's going to become suicidal, but that's another that needs to study it further. But the point is, PHQ-9 can be very useful, especially in terms of caretakers when they may have unrecognized depression and other related things. Similar with some of these cognitive tests, we recognize the importance of early cognitive impairment. All early cognitive impairment does not go to Alzheimer's. A very, very important point. So early cognitive impairment can be a problem in everyday life. We have a lot of strategies to deal with that now, other than the stuff you see on TV. So just recognize that it's important to keep track of your cognitive function and your emotional state, but do not go overboard and think that it will necessarily lead to severe psychopathology.
Hey, did Dr. Anel Prim develop that PH9?
No, she didn't. That's another whole story in itself. It's actually developed by Pfizer, and it was developed as part of a general attempt to try to have primary care physicians being able to diagnose psychiatric disorders. There were about 4 or 5 other instruments, but the PHQ-9 is the one that survived. And we are now trying to develop other instruments that can deal with the whole wealth of different kinds of disorders. For instance, they can't diagnose bipolar disorder, and it does not do a very good job for the anxiety.
Thank you so much. I really appreciate everybody for joining us, and we're about to sign off, but I want to remind everybody, if you haven't, please vote. And vote for people who you feel will support you and your community and the things that you hold dear, such as voting rights, women's rights, and fairness, and anti-racism. Thank you so much. Have a great day. Enjoy yourself. Thank you, Simon.
Thank you, Dr. Maxey, for inviting me.
Be well.